Thanks, Indra. Good morning, everyone. Welcome to this session. In a moment, I'll be introducing you to our fantastic panel, but I was asked to give you a very quick few words about NHSx and what our role is within it. I'm a public health doctor by background, and I'm the Chief Data Officer of NHSx. For those of you who aren't aware, NHSx is a new joint enterprise between the Department of Health and Social Care and NHS England. We definitely got the flavour of the month with the letter X and CogX, but in our case, the X stands for the user experience. So our raison d'etre really is to improve the lot of patients and staff, the end users of technology. What's NHSx's role in relation to AI? Well, my colleague Anna describes it as a bit of a dual personality. So on the one hand, we're there to champion AI. On the other hand, we're a bit of a damp squib, as she put it, which I thought was a bit harsh. What does she mean by that? Well, we're very much there to champion machine learning and artificial intelligence. I'm probably one of the biggest fans of it. I think we're on the cusp of something quite remarkable. For those of you old enough to remember the late 1990s when people were starting to talk about this thing called the World Wide Web, just look at what's happened since then, and I'm getting déjà vu to a large extent on that. One of the things for me is how AI is not just going to replace humans, but rather to do superhuman tasks. I don't know how many of you use Google Photos, but if you use Google Photos and you enable the facial recognition element of it, it's quite outstanding. I could show you some photos from my Google Photos album of photos of me as a toddler and my sister and my niece and my nephew. If I'd have brought them here for you, I'm sure you would have struggled to work out who's who, whereas Google just automatically picks them up. It's quite scary in a way. What's that got to do with healthcare? Well, in healthcare, we often use imaging, CT scans, for example, and may have to inject what's called an IV contrast into the patient in order to show things up on that image. That's not without risk. Some patients can have an allergic reaction to it. The exciting thing about AI is sometimes it doesn't need to have that contrast because it can pick up things that the human eye wouldn't be able to do. So that's the kind of championing element of it. What about the damp squib? What do I mean by that? Well, there's enormous potential for AI, but we need to do it carefully. And so part of our role is to think through the ethics of it, the information governance and the safety. So, for example, everything we do needs to be compliant with the General Data Protection Regulation, the GDPR, and with the Common Law Duty of Confidentiality. When it comes to ethics, we need to be very, very cautious. So whenever AI is making a prediction, sometimes that prediction will be incorrect. And we need to be really careful that what is called false positive and false negative results don't cause more harm than good. And then finally, in relation to safety, many of you, I hope, will be aware of the new Medical Devices Directive, which comes into force next year. So we all need to be really mindful of that and make sure that we're abiding by the law. So NHSx, I hope, is going to try and strike the right balance between the excitement and the note of caution. Just going to give you a quick flag of a few of the things that we're doing in this space already. Probably the most important is the AI Code of Conduct, which Indra has worked on. Do have a look at that if you haven't already. We've got 10 guiding principles on there, but they're very much just a starter for 10. And so we're looking forward to consulting more widely on that later in the year. My team are developing what's called an IG framework for integrated care. So one of the problems with the NHS is that it sometimes behaves like the world's 5th largest organisation, but sometimes behaves like 8,000 or 9,000 separate legal entities, and trying to navigate that and getting the data flowing between them can be a major headache, but we're hoping with this new framework on IG that we'll be able to help make things easier on the ground. That's part of a bigger package of work to try and simplify and rationalise and modernise information governance. Those of you who've worked in the NHS will know that when you mention the letters I and G one after the other, you instantly get people rolling their eyes out of frustration. Part of my role is to try and do something about that and make people see IG as something positive and helpful. A little bit how health and safety gets a bad rap, with all the people thinking that health and safety's gone mad. But if you look at the improvements in mortality from accidents over the last 30 years, it's quite dramatic. So hoping to have a similar revolution in IG. We've got a big range of initiatives to try and improve access to data. So the new digital innovation hubs are going to be launched later this year, the first 4 of those, quite exciting. That's part of a bigger piece of work to define the future architecture for how NHS data should flow around the system, so keep an eye out for that one. And then finally, on transparency, you'll be aware that the Secretary of State published his credo in relation to data and tech last September, I think it was, and we are in the process of developing an annex to that document which sets out. I'm delighted to introduce Caroline Cake. Caroline is the Chief Operating Officer and Deputy Director at Health Data Research UK, HDR UK, which is the National Institute for Health Data Science, and they are the masterminds behind the Digital Innovation Hub programme. Caroline is responsible for developing the strategy and running the organisation and the digital innovation hubs. She's a chartered engineer by background. She started life working in the electronics and chemical industries before becoming a management consultant. She originally worked for McKinsey and then for the last 12 years as part of the leadership team at 2020 Delivery. So please, with a big warm round of applause to welcome Caroline to the stage.
Thank you, Geraint. So lovely to be with you all here today, and I'm going to be covering three different things in the talk that I'm going to give, a brief talk just before we get into the group discussion. So what I wanted to cover was three different areas. First of all, to introduce you to Health Data Research UK, and secondly, to talk a bit about health data science and what it is we're doing at Health Data Research UK to bring that to life. And then the third part, to talk about us, the people, and the public, and how this all affects us and how we can get involved in it. So I think if I click forward, yes, it works. So first of all, this is just setting out about Health Data Research UK and what our mission is, which is to unite the UK's data to enable discoveries that improve people's lives. So this fits very nicely with the conversation that Natalie Banner and Baroness Blackwood were having beforehand. It's about how we have this extraordinary data assets, but how are we actually using them to make a difference to people. Our longer-term vision, then, is about actually how you can use this large-scale data and advanced analytics, so including AI, machine learning, to actually benefit every patient interaction. So it's making sure that every intervention you have with medical care, with how you even think about your own healthcare, is actually informed by healthcare data. And what this is going to entail is actually three different things. So this is what... I'm not moving forward. There we go. That helps. So it's going to entail three different things. So we've got the science, which is around, we've got 22 different universities that are part of Health Data Research UK, and they're doing all sorts of exciting science, which I'll talk through a little bit in a moment. Then the people side of things, and Baroness Blackwood also alluded to this, the importance of actually having the health data scientists who can do the work, who can use the data and turn it into the discoveries and valuable insights that we need. And then finally, the infrastructure, and this is the Digital Innovation Hubs programme. So I'll talk about how this actually, the plumbing of how you actually get access to the data and how it makes it happen. And all of this needs to be underpinned by patient trust, public trust, and good governance to make that work. And that's been really stressed a lot in the previous conversation as well. Now, when we talk about data, what do we actually mean by it? So this chart just shows kind of the three dimensions of data that at Health Data Research we're thinking about. So you've got, if you look on the vertical axis, you've got the kind of the population, so all 66 million of us, and actually all of our data. You've then got the axis in terms of over time, so how our health and how we are over time evolving. And then the depth and detail of the data, so the different types, the multimodal data that we have in there. So, for example, our genetic information, our routine data, when we our last trip to the GP, that side of things. So there's a lot of different information out there. The big challenge is actually how it's connected and how it's linked so you actually can use it, how you overcome the silos to actually make this useful for research and for innovation. Now, I mentioned our science side of things. So we've got 6 priorities that we're working on at Health Data Research UK across the different universities on the science side. And they are around the human phenome, how that's been mapped, so similar concept to the human genome, but going into the phenotype. Applied analytics, so how AI, so we have a joint appointment with the Alan Turing Institute, thinking about actually how do we actually apply the AI tools and techniques into health. Thirdly, understanding the causes of disease, so really understanding the underpinning causes and from that and using large-scale data to really help us understand better different types of diseases and how they manifest themselves. Then getting into clinical trials, so that was touched on in the previous conversation as well, around how you can actually use large-scale data to make trials faster, quicker, get to better, more accurate outcomes. How large-scale data is used in public health, so how we're thinking about informing public health decisions so we all make better decisions around our own care. And then finally, the last aspect is digital health insights, which is around how those benefits are then turned back into better interventions and interactions with the NHS. Now, I talked about people briefly. So what we're looking to do is to create 10,000 health data scientists across the UK. So this is a huge area, really big opportunity, and I think anyone who's thinking about this field, it's incredibly exciting, and please encourage your friends, your colleagues, or kids who are thinking about this as a new career, a new opportunity that brings together really interesting aspects. So I come as an engineer into this field, others coming as clinicians into this field, others coming in as statisticians or computer scientists. So it brings together all these different skill sets that we need to be able to actually transform how health data is being used. I'll get into the Digital Innovation Hubs programs. This is the infrastructure component. Let's think about it as the plumbing of how things work. So what we're doing is, and Geraint, as Geraint mentioned, is creating what we want is the UK to be the leading place for health data research. And what we're doing is putting in place the leading infrastructure to allow that to happen. So we have the fantastic data, we have the fantastic researchers, we have the great life sciences industry, strong kind of support from government, but it's actually how do we make the actual data work from that point of view. And what we're doing is actually focusing particularly initially on curating data sets, clinical trials, and real-world evidence. And I'll talk a little bit about those in a moment. Over the last 6 months, what we've done is work with over 2,700 people. So we've engaged with people from NHS, from academia, from industry, and with patients and the public, with charities, to really understand about what people are wanting, what their concerns are, what obstacles there are to actually doing health data research at the moment, and innovation, and really then what pieces we need to put in place. We've also looked at other sectors to see actually how things work in the banking sector, how things work in communications, in telecommunications sectors, to see actually who solved these sorts of problems previously and how did they do it. And the key messages that came out from the conversations are it's really about people love the fact there's all this great data, but the difficulties in accessing it, how long it takes to access it, and then once they've accessed it, the quality of the data they have. So it's sitting in all sorts of shapes and forms. So once you've actually got it, how you actually get it to a form that actually can be used is very important to people. We also heard the clear message from the public that actually people like the idea of data being used, provided they understand it's transparent what it's being used for, and they can see the benefits feeding back into the UK, into the NHS, and for the wider population. So the design that emerged from this dialogue and conversations is this, which has 3 parts to it. So the first is the Alliance, and this brings together all of those organisations that hold data assets, and many of you in the audience may be organisations that are data custodians. And what we've done is bring together the kind of first of these. So we've got 9 organisations that come together from across the NHS, from other organisations, including Genomics England, CPRD, and bringing together and working on the points that Geraint was mentioning over actually how you get consistent standards in place, that everyone's lined up and thinking about how we're making the kind of shared vision around how we're making the data accessible and what things we're putting in place around access arrangements, around how we're thinking about IP, how we're thinking about information governance. So that's what the Alliance is for. That then works in partnership with the Digital Innovation Hubs. These were a competition that's been launched for the first of these at the beginning of May. And this is bringing together providing value-added services to the data. So we've got the data in the Alliance. It's then actually how you improve the quality of that data. So providing curated data sets in disease areas, so cancer, cardiovascular, those sorts of areas. And then thinking about actually how we provide the value-added services around clinical trials, so how you can use that data to actually make clinical trials faster, more effective, and then about real-world evidence, so how the data can be actually used once drugs or treatments are in the community, how we're using the real-world evidence to tell us, is it working, is it doing what we expected? And then the final part then is the gateway. So this is a common access point for health data, so that if you're an innovator or you're a researcher from an SME or from industry or from the NHS, you've got a common route to actually find the data, to know what exists, first of all, to discover it, to get an access route through it, and then starting to think about then how we make linkages between that, how we make that possible, and how we have aspects such as phenotype library baked into that, so that you're having a common same way of accessing the data. So those three parts work together. So the alliance, the hubs and the gateway together is our proposed approach to actually making a trustworthy approach to using data, and also to enabling the feedback loop to the patients and the NHS. So I'll just kind of touch on each one of them, just giving you a broad sense of where we are with each of them. So the Alliance was started earlier this year, and we've had the first board meeting of the Alliance. So you've got organisations such as NHS Digital, NHS England in there. We've got, as I mentioned, the other ones across there. And what we're doing is working through a programme of work of actually putting in place the agreements and the standards so that things can be more accessible. Next part then, the hubs is the other part we have to this, which is drawing on expert international advice around ethics, so that we're actually considering data protection, getting the best advice on how to think through on that. Then into the hubs themselves. So we're looking initially, first 5 of these being available through the funding we're doing initially, but then looking to add on in the future would be fantastic, that other organisations are bringing things through on that. So this is up and running from the competition closes on the 2nd of July, and then we're looking to announce those in autumn time, with the idea that they're up and running later this year. And then the gateway. So this is in design at the moment, and we're looking for getting that out later over the summer, so that we can actually start building the minimum viable product of that and having that running through the year, so that by the end of the year, the 3 parts are coming together: the data sets from the Alliance, the improved curation services starting to come and play from the hubs, and then actually having the gateway providing an access route to it. So there's a lot to do, and it's incredibly exciting to bring all the pieces together, and relying on working so closely with all the different partners, as you can imagine, all the different organisations involved in all of this. But it should hopefully put the UK in a very unique and world-leading position. One of the other things you may have heard about is to inform the work we were doing, we initiated a set of sprint exemplars. So these were 10 different kind of initiatives that we funded at the start of this year for 10 months to actually learn and form the design of the Digital Innovation Hubs programme. So these are existing across the UK, so up in Manchester doing some fascinating work on heart failure, and actually how working with patients in terms of informing decision-making on that. Linking work going up in Scotland, up at Edinburgh, and then work over in Cambridge, also on bringing together the rare diseases side on that. So there's some really interesting pieces that what we want to do is to learn by doing, to actually start making things happen, to seed and catalyse. And what we're doing is bringing together regularly those groups to really see what they're learning as they bring together their partnerships across academia, the NHS and industry, and with patients, to see actually what's happening. Is what you're expecting to happen, what's new? What's it going to take to really seed this at scale across the country? And so just going back to my first slide, which is actually why we're doing this. So we're doing all of this so we actually do bring together the UK's data so we can make discoveries that improve patients' lives. And that's people across the country. That's you, that's me, that's all of us thinking about actually how is our data being used? How can we, and how do we build that public trust in a way that we actually are sure and confident this is working the way we want it to be, but also how do we start demanding that our data should be being used so that we do get these better results and better outcomes on that, and thinking through that. So I think thinking very clearly about what our role in all of this as well. So that's exciting place to be on this, and look forward to the conversation.
Thank you. If I could invite Jess and Matt to come up and join us on this stage, please. So Jess is one of NHSx's AI leads, working alongside Indra. She's also a researcher at the Oxford Internet Institute's Data Ethics Lab, and is the co-lead of the One Health Tech Oxford Hub. Jess is primarily interested in ensuring that the NHS is able to capitalise on what's called the dual advantage of the ethical use of health data. That's to say, where it's aware of the risks and is able to mitigate them appropriately in order to capitalise on the opportunities. Also delighted to welcome to the stage Matt Whitty. Matt is the Deputy Director of Innovation at NHS England. His main areas of responsibility are being the programme lead for the Academic Health Sciences Networks and the testbed programmes, and he's also the Policy Development Lead for medtech funding mandate, testing infrastructure and the adoption and spread of innovation. So I think, Zara, am I right, we've got mics to go around in the audience if people want to ask questions. Is that the plan? Yep. But let me kick things off. Matt, actually, why don't I start with Jess? Jess, there's a lot of talk, and has been for quite a while, about the potential uses for machine learning in healthcare. How do we move from sort of hypothesising and pontificating about it to actually doing something in practice on the front line?
Yeah, that's a really, really good question. I think we have to start moving from the what to the how. So we've spoken a lot about what is possible, how do you... Am I not loud enough? Sorry. Apparently, despite the fact that we are the health stage, every single person who's speaking today has lost their voice. So sorry for that. Yes, we have to move from the what to the how. We've spoken a lot about what is possible and also what should be the rules of sort of ethical AI. And now what we are doing is running a program of deep dive case studies into what is actually possible and how you go about implementing that on the front line, so that by the end of the summer we will hopefully have a list of like what is best practice, so that we are able to assess against that. And I hope people will stay for the next session when you'll actually hear some of those case studies in more detail.
Great, thank you. Matt, how do you see the environment changing over the next few years to sort of promote the use of AI within the health sector?
Well, in a nutshell, I'd hope that it's going to be a lot more joined up, and things that we're doing at NHS England to support that. So the team that I work with within NHS England is the Innovation, Research and Life Sciences Group. And we're shortly going to be moving over to what's called the Boosted Accelerated Access Collaborative, which has got two aims, really. The first aim is to improve the pipeline for innovation, and then the second aim is to actually improve the uptake of those innovations. So two of the areas that I'm working on are improving the testing infrastructure. So we've currently got a testbed program that we're working on. So this is where we can bring together digital products and actually test them, firstly to test whether the technology works in the NHS setting, and secondly to test whether in that setting it can make the sort of the claims that are usually accompanying the business case, be that productivity savings or other types of savings as well. So the testbed program will sort of help with that. So secondly, we're also developing the medtech funding mandate. So from April next year, products that have been through NICE and have positive NICE guidance through medical technologies guidance or a diagnostics assessment program and deliver cost savings, they will be mandatory for providers and commissioners to make available to patients. So this will be quite a big change in practice, because we're aware that some things do go through NICE. They don't quite get the traction when we actually look through the data for what the uptake is like. So by mandating that, we're hoping that will provide a stronger incentive for those things. So that's part of the work that I'm working on, and overall with the AAC, hopefully that will be a lot more joined up.
Great. And Caroline, what do you see as the kind of ultimate prize for the NHS, and more importantly for patients and the UK population as a whole?
So I think the prize is very big. It's incredibly exciting. So earlier diagnosis of disease. So you can see things already going on. I don't know if anyone saw the things on in Addenbrooke's in terms of the work they're doing with rare diseases for kids and finding out actually what's going on earlier. The interesting things going on Alzheimer's Research UK on looking at basic things in terms of actually how your phone, in terms of your gait and your tapping on the phone and things, can you actually start spotting Alzheimer's starting to happen? So there's all sorts of absolutely fascinating things on early diagnosis that are potentially very interesting. There are then kind of aspects in terms of really understanding diseases better, the underpinning structures of diseases. So we actually really understand actually something that might be manifesting itself in one way in one person and differently in another, potentially is the same disease. And actually starting then you can understand how to treat them better, then getting to better treatments. So if we've got the clinical trials on much larger populations and actually using them to actually find the patients who are most appropriate for those trials so we get better outcomes from that. So there's great work that Oxford and NHS Digital are doing on that at the moment. And then things like actually providing better care, so the work I mentioned that was going up in Manchester on heart failure monitoring, so they can actually get earlier interventions on people before they actually get to a kind of acute stage, emergency stage of needing to go into hospital. You can actually intervene at an earlier point. So the benefits from this are really, I mean, extraordinary and transformational for all of us. It will help the NHS, it will help each of us as individuals. So I think, yeah, very exciting.
Brilliant, thank you. Who'd like to kick us off with a question from the audience? Don't be shy. Gentleman over there.
Across the Across the UK, there are obviously areas of different degrees of digital maturity, and the HDR are obviously very interested in real-world data. What's the strategy to ensure that we don't have particular areas, geographic areas in the country left behind by avoiding funding areas that are slightly further ahead?
Great question. There's a next question down there, Zara, when you're ready. Yeah. Who'd like to pick that? Do you want to kick us off on that?
Shall I start from an HDR UK perspective? I think there's obviously going to be an NHS perspective and things on there as well on that. So from our point of view, we are looking at national coverage. So we have sites geographically located across all 4 nations, and from that perspective, so wanting the science to go on at nationally, that's obviously different to then where the data is available and the digital maturity on that. So obviously we're at stages of different hospitals with their EPR systems and the levels of development on that then does put insights in different places. But we think that by providing the national scientific aspect on that and the people area, we can then and what we're doing is moving to national priorities rather than geographically located. The insights coming out of the work will then benefit and feed back into people no matter what part of the country they're in on that. So as much as, and I think the key thing on that is perhaps also ensuring you've got the diversity of data coming through. So but that's not always correlated with the kind of where the maturity and things are on that. But ensuring we've got a good mix of people. So you find some populations are very good at providing lots of data, and others are less enthused by it. So you end up with a different profile of data coming through on that. So pushing that aspect is also important from our point of view.
Thank you.
Well, one of the other routes that we use to spread innovation is the Academic Health Science Network. So we do have national coverage through the AHSN network and through a commission that they have from the Office for Life Sciences, which is part of part of BAYS in government. They are working on developing real-world evidence and real-world testing across the country as well. So we have got that national spread as well. Additionally, as part of the Accelerated Access Collaboratives remit, we're looking to have sort of more joined up horizon scanning. So as part of that, we're looking across all of the different horizon scanning activities that are going on. We're looking to develop what are the research and innovation needs that are coming out of that. And again, we're working with the Academic Health Science Networks on that as well to help get that picture, which will feed into our plans for developing the testing infrastructure as well.
Thank you. The question down here at the front.
Yep. So my question was around the digital innovation hubs, where you mentioned that they would be focused on specific diseases. So I wondered whether there was specific diseases you had in mind. Is this about cancer or diabetes, mental health? Like which ones?
Yeah.
Are you looking at?
So this came from the industry and kind of innovation user perspective. They particularly highlighted diseases that they would find valuable and useful. And cancer, cardiovascular, all the ones you listed there were mentioned on that. But what we're asking each of the hubs to do is to think about actually their own sustainable model. So if they can demonstrate that they will be, actually there is a real user need for what they're doing, and that's what we'll be looking for through the process on that. So that will also help. So if people come in and say, actually, there's this one you didn't mention, but actually, look, there's this huge need for it, and that will come through on that.
Thank you. Next question.
I'm an entrepreneur in this space, so I'm trying to make money. And being bold, that's true. And we've been looking at working with about 7 or 8 NHS hospitals about taking data from them to process it and do some deep tech, to do some interesting image work on cancer MRI. What is the view of the panel about the obligation between the NHS and an individual company in terms of equity shares, royalties, or just use of technology?
Thank you. There's a question with the chap with the grey T-shirt next, and then I'll come back to you. Who wants to kick us off on that?
Two parts. So I think one, this has been one of the areas where it has been disjointed, and it's just sort of been left to the market. So there's a couple of pieces of work going on around sort of the value, particularly around the value of NHS data. So that's looking at what is the consistent way to do that. Firstly, so that the NHS gets the benefit if something suddenly takes off and potentially becomes a royalty stream further down the line. But in the short term, actually, the focus has been around ensuring that NHS organisations do not sign up to data arrangements which are too restrictive or will prevent sort of greater, the broader benefits. So I guess sort of the short-term focus is on not signing up to very restrictive data agreements. In the long term, there are a number of pieces of work looking at sort of the value of data and how we best do that. There's obviously issues around sort of state aid if it comes to taking an equity share that we need to be considerate of. So it might be royalty streams as well, but we're at an earlier stage for understanding the legal implications of that.
Thank you. We had a question in the middle there.
So I had a question that, like NHSx and everyone, amazing technology is being developed around the world, but one of the most common problems everyone is facing is adoption of the technology by existing healthcare workers, doctors, nurses, and everyone in the system. So my question is, what would you say is the primary reason behind this? And how do you think you will address this in a way that we can get these technologies faster to the patients?
Thank you. Great question. Jess, do you want to have a go at tackling that one? Thanks.
Thanks. I very much doubt there's one particular reason. There will be multitudes of different reasons depending on the specific context, but I do think one thing that we have done really badly in the past is try and tell clinicians what technology we think they should be using, and also to say technology innovation for the sake of technological innovation, and events like this sometimes don't help with that because they try and amp up the hype. So one of the things that we are actively trying to do is kind of cut through the hype so that we're actually taking an evidence-based approach. So a few things that we're doing as a part of that. One, we're actually doing an active piece of research where we are doing some qualitative interviewing of frontline staff. And similarly, we're doing the same piece with patients to understand what it is, where are the pain points in either providing care or delivering care. So just take the technology out of the question. What is the worst parts of either delivering care or experiencing care that we then believe through the survey mapping exercise that we have been doing and the horizon scanning exercise that Matt mentioned, we know is available. So we can try and create the pathway to bring together that sort of supply and demand, regardless of what that technology actually is, instead of saying, hey, here's a neural network that does this, everybody use it, please. Just be a little bit more strategic about that, and then hopefully, if we have the evidence and the need base, the sort of reason why you would adopt is a bit clearer.
You've got a thumbs up there from the train driver, I think. Yeah. Matt, did you want to add anything to that? Or
So I completely agree with Jess. Evidence is one of the main things that we hear in terms of that, and then things that we've done to address that. So we're moving away from sort of an NHS England view of we think this is the right thing to do because we've heard it from this clinician or this group of clinicians, and much more moving towards using models where we use NICE to make that, because it's the best place to have those discussions, to gain that consensus, to test the assumptions in it. So using NICE more is one of those ways, and we're looking to put more digital products through NICE as well by expanding NICE's capacity for doing that. One of the other things that we do here with adoption spread is sort of the not made here problem. So it's it's a southwest thing, and we're never going to use it in the southeast, or it's one particular area. So that's another thing. So part of the testbed program, for example, that's why we're really looking to see, can it actually deliver the business case assumptions in there as well as does the tech work. And one of the ultimate measures of success for that programme will be, following the completion of that, how many other sites choose to adopt that technology based on what they've seen from the test beds as well.
Great. Did you want to add anything, Caroline? Or?
Yes, I think also just thinking about actually, clinicians are incredibly busy people. So I think any of us who've spent time with on a ward or in different areas, they don't have a lot of time to be thinking about attending conferences, doing etc. On that. So it's actually building it into their place of work and actually building and designing it into the tools that they use, so that it's easy for them, rather than actually making it hard work for people to find out what's going on and adopting and things on that. So I think thinking about how you design it in.
Great, thank you. So we've got a question down here, and then one in the middle, and then I'll come to you. Thanks.
Thank you. This is a challenging question, I hope, but one of the things that becomes self-evident to anyone trying to deal with the NHS is that there isn't an NHS. There's a sort of conflagration of different NHS things, each of them acting to sort of individually, such that fostering agility in the NHS is one challenge, but fostering agility of the NHS is another. For example, I tried to determine who owns a dead patient's health records. And EMIS believe they may own them. The NHS believe they may own them, and equally the family of the deceased may have some say in them as well. Could you tell me, for example, who would be able to determine who owns a dead patient's records inside the NHS?
Shall I have a go at answering that one? So I think probably the problem is that the premise of your question. So I own this pen. I bought it off Amazon. It's my pen. If I choose to give it to Indra, it will become Indra's pen. Compare that with an email. So if I send an email to Indra, who owns the email? Do I own it? Does Indra own it? Does my employer own it? If I forward it to 15 people, who owns it? So ownership and data, the concept just doesn't work. And so in this country, we tend to think of it instead in three separate categories. So there's what's called the data controller, who has the say over how those data are used. There's the data processor, who actually does the doing. And finally, there's the data subject, who's the individual person. If you want to have a chat about deceased records, come and grab me afterwards and I can put you in touch with our information governance team. But I think that's probably the problem, is that ownership is just too simplistic a concept when it comes to data. Does anyone on the panel want to add anything to that? No? So the question just behind there. Thank you.
Hello. Question to Matt, mainly. So I'm an interesting case when we talk about test beds, in that I was working for a big industry player, and one of the Wave 1 test beds, and big hopes for that combinatorial innovation and how we're going to roll it out. I'm now director in the HSNs, by the way, so I flipped to the other side. But we still have a challenge, and I was struck by the gentleman at the front talking about industry, which is when we've evidenced something in the test beds, how, beyond simply saying it works, how can we get beyond some of the procurement barriers that say this is a combination of both the NHS in terms of its processes and people, and a combination of technology which has been evidenced as working? How can we put a sort of stamp on that allows CCGs to be confident in making decisions to actually spread it? Because there is a spread opportunity locally, but we're all aware there's a spread opportunity nationally for some of these bigger innovations. Thank you, Matt.
So there's three parts to my answer on that, really. So firstly, we also see the same procurement challenges that you're alluding to around some of these products. So we've got our innovation and technology tariff and innovation and technology payment products, some of which have very similar procurement challenges. So again, we're sort of working through in the short term for those specific products. From that, we're also, with my medtech funding mandate hat on again, we've got to think about the procurement routes for that. So we're talking to SCCL, we're talking to the people in procurement, we're talking to the ABHI to sort of understand what those procurement barriers are, we're talking to the category towers, we're talking to Health Tech Connect to sort of see how we can actually piggyback on some of their processes for getting these things listed in the appropriate way. So I think those would be those would be sort of some of the main ways we're looking at it. It is a challenge, and part of the issue is that we're running to, so just for people who are maybe less aware of the issue, is that what we don't want with the funding mandate is to have the funding mandate in place and say, great, these are the things that we want adopted and spread, and then run into a procurement barrier that takes a year to work through as well. So we are completely working on that, but we certainly don't have all of the answers for that at the moment.
Right. Anyone to add? No. Next question. Thank you.
Hi. Before it was mentioned that the average uptake for innovation is 17 years. I got two questions interlinked. What is your forecast with the new organization? I work in the business side, so I have to ask this. And will there be a maximum amount of time for the test beds to reach completion? Are we looking at months, years, decades? Thank you.
So who wants to make a prediction, bearing in mind that this is being recorded so we can go back and test your accuracy in a few years' time? Yeah.
I'm not going to predict it. I mean, that's mine. I put that in Nicola's speech. But so I think that actually comes from the fact that typically it comes back to the question that we had before. Some of that is related to technologies that also require training, and that therefore slows things down. I think we also have to come back to the point around the fact that if there is a clear identifiable need that's not related to the technology, it will be easier to uptake it. Like if we go back to 2007 or even 2006, I don't think anyone woke up one morning and thought, you know what I really need is an iPhone. But we didn't have great mobile web, and so therefore there was a need for an app, and then the iPhone came in and it filled that very specific need. In terms of how long do we go from testing through to implementation, that is a question that's a little bit how long is a piece of string. I don't know if you have seen the NICE evidence framework for effectiveness, but it's based proportionally on risk. So if there is something that requires only a small amount of evidence, because we know that it's going to be clinically effective, or even if it isn't clinically effective for everyone, the amount it presents of the risk is proportionally small, then we wouldn't need to test it for as long. But if we are talking about something that actually we need to identify whether there's biases in the data sets, and we need to make sure it works in this particular instance and that particular instance, then I'm not going to put a cap just for the sake of getting it into the NHS at scale fast. So it's got to be context specific.
Thank you. Either of you foolhardy enough to make a prediction for us? Caroline, Matt?
No.
But yeah. Thank you. So next question there in the middle, please, Zara. Lady here. Thanks.
Thanks for a really good session. So as a doctor, when I go into the bowels of the NHS data units on the ground, what I see is very different. So it's, the glitzy stuff's often at the surface or at the national level or in government bodies or in special projects. But the reality of day-to-day life involves still many Excel spreadsheets, proprietary visualization tools, not good support for coders who perform the basis of all our performance data. Caveat, I have a company as well that is doing well in that space, but not in the UK. We're making nice amounts of money in other countries, but not in the UK, because some of these things are kind of missing on the awareness screen. So my question is, when I talk to these people, back to the people on the ground, the data analysts, the tech people and the coders in NHS hospitals are often have rudimentary skills, are not given training or updating, and they're rather terrified with this juggernaut coming round of change. They're wondering basic things, will their jobs be taken over by machine learning, which frankly they should be, and they will, because some things machines do better. They're wondering, can they upskill? They're wondering what kind of skills they'll need to get next. Is there a roadmap for anything about transforming the NHS workshop that are not clinicians?
Thank you. Great question. So delving into the bowels of NHS data, as you put it, and what we're going to do to improve bowel health.
So I'd like to think of it perhaps not as a vowels, but these group of people are incredibly important to, and this is one of these and why we've got it as one of our top 3 things, of actually that group of people and thinking of them as health data scientists and helping them build a career and being recognised as not admin and clerical at the bottom of the pile type of thing in terms of, but actually you are a profession of which you then need to be thinking through the skills, the journey, things on that. So we're putting in place parts and also working with Health Education England in terms of thinking through actually what is the route for individuals and what's the career path, how do you think about the links across NHS, academia and industry, because these individuals can move into those different places. So it's a hugely exciting future career for people in that space. And yes, some aspects will be replaced by technology, but actually drawing the insights and the value out of it, there's this huge area of opportunity for people to get into. So I'd hope that if we can tell the story, that actually there's a big opportunity for them there, because we need more people in that space rather than fewer on that.
Great. We're running out of time, so we're going to step it up a notch into kind of quick-fire questions, if that's all right. One at the back here, and then there's one more over there. If anyone else has got a burning question, pop your hand up and I'll try and come to you.
Hi, yes. I was wondering if NHSx does many projects around operational optimization, so logistics and supply chain optimization for cost savings.
Do you want to have a go at that one, Jess?
I think that depends a little bit on what you mean by does NHSx run any projects like that. We do in terms of, yes, we are looking at those types of test cases. So actually you'll hear one, if you stay, around operational efficiency from NHS Blood and Transplant, who's doing some really great stuff. So is NHS BSA, which is the Business Services Authority. So we are collectively, like from a horizon scanning perspective, aware that actually that's probably where we're going to release a hell of a lot of the value, is from that type of back-end stuff, the non-sexy stuff. But as does NHSx run the project ourselves, that's not our role.
Thank you. That's it.
Hi, thanks very much. As an NHS clinician, one often sees that IT infrastructure within the NHS is already unable to cope with day-to-day basic function. How does one envisage that not being a problem as we seek to implement new technologies?
Did you catch that? Do you mind just repeating the number of your question one more time for us?
So I'm a clinician, and at the moment, basic IT infrastructure within the NHS is unable to cope with basic function. How does one envisage that not being problematic as we seek to implement new technology in the future?
Good question. What are we going to do about the sort of bread and butter technology that staff are using on the ground? I think it's your question, isn't it? Yeah.
I mean, there's a few things that we can do. One, we have to sort of move towards a model that we are actually thinking about full stack development. So quite often we have gone in and said, right, let's put the shiny thing at the end, let's put the cherry on the cake without understanding all the ingredients that are in the cake. We are now moving away from that model where we are actually trying to see, like, if we were going to implement a clinical decision support software in a hospital, what are all the layers that sit underneath it? The second thing is NHSx's real move towards standardization and open standards as opposed to the actual infrastructure. So we've kind of had this weird history where we either did the national program for IT, or then everyone went, whoa, that was bad, so let's try and let everyone else kind of do their own thing. But instead what we're trying to do now is create the environment and say, as long as you're operating within these frameworks, then you'll go ahead and choose. But that then does also mean that we are simultaneously giving choice to the people who are putting that stuff in a hospital on the ground, but we're also making it very, very clear to providers of those types of technologies that if you are not abiding by these standards with regards to interoperability, usability, user experience, that's what we're all about, then you're not going to play in our playing field.
I think Caroline wanted to commit.
But I think you're right as well in terms of the unless if you're a clinician who can't get access to a computer on wheels or whatever, and you're sitting queuing up and having to wait till 8 o'clock in the evening before you get to enter your data. I mean, it's just crazy. So we have to make ways of making it just easier to enter in things, get the data in right first, rather than having to spend lots of money on curating data after the event because it didn't get entered in at the right time or the right way initially. So there's a lot by actually getting it baked in and solved at the front line will make the data a lot better. So I think it is a really important point.
Thank you. On that positive note, can I thank you, the audience, for some fantastic questions, and to our panel for their very thoughtful answers. Thank you.